It's my pleasure to introduce our next speaker, Dr. Gregory Pearson. Dr. Pearson's a cardiothoracic radiologist and body imaging specialist at the Westchester Medical Center and an emeritus associate professor of clinical radiology at Columbia University. His areas of interest include lung cancer screening, cardiac CT, and the use of AI tools to enhance radiology practice. He received an MD and Ph.D. degrees from Harvard Medical School and the joint Harvard-MIT MD program in health science and technology. After an internship in internal medicine at Boston City Hospital, he completed a diagnostic radiology residency at Brigham and Women's Hospital and a fellowship in cardiothoracic imaging. His talk today is titled Functional Information from Coronary CT Angiography, the Case for CT Fractional Flow Reserve. Welcome.
Thank you. Nice to talk to this overflow audience here. This is, in some ways it's kind of the easiest talk to give because I know I'm talking to people that I tend to know more of my subject than they do. On the other hand, it's also kind of the hardest talk to give because I don't know what level people are coming from. Can I say CT scanner and have everyone know what a CT scanner is? So I'm going to kind of go back to the beginning. History of coronary CT angiography. This is one of the most technically demanding studies in all of radiology. Coronary arteries are small. A big coronary artery is only about 4 or 5 millimeters across. And we can bypass vessels down to about 1.8 millimeters. So we're looking at pretty small vessels here. And the heart is a moving target. If you have a heart rate of 60, that's 1 second per heartbeat. That's 1,000 milliseconds. And the heart is moving back and forth in a very complex manner over that 1,000 milliseconds. So we have to try to catch places at the end of systole or the end of diastole when the heart is not moving much. And that's a very short period of time. So what I'd like to do today is briefly review the history of coronary CT angiography and describe the new technique of fractional flow reserve CT, which has recently had FDA approval and a Class II recommendation from the American College of Cardiology and the American Heart Association. So again, trying to go through this pretty quickly. CT scanning goes back to about 1972. That's when Hounsfield created the first CT scanner. Trust me, it didn't look like this. This is a more modern CT scanner here. But early CT scanners, we attained CAT scans in slice thicknesses of about 5 to 10 millimeters. And the tube rotation time was about 1 second. So you can imagine trying to take a picture of a heart with a scanner like that. You could take a picture of the heart, but you were not going to get good pictures of the coronary arteries. And the remarkable thing is that was back in 1972, and not a whole lot changed over the next 25 years. Scanners got a little bit faster, the slices got a little bit quicker, reconstructions went a little bit faster, but the basic technology stayed very similar. It was not until 1998 that the first multi-slice scanner came out. That's when people figured out that instead of just taking 1 picture per tube rotation, we could use an array of detectors and get 4 more pictures for a tube rotation. But still, back in 1998, we were still using down to maybe about a 1 millimeter slice and maybe about a 250 millisecond temporal resolution. So that was 1998. From then, things accelerated really rapidly. 1999, we came out with the first 16-slice scanner. In 2001, the first 64-slice scanner. It was these 16-slice scanners that we first started to say, well, can we actually get a good enough picture here to say something useful about the coronary arteries? And those scanners had about a 210 millisecond temporal resolution with about a 0.75 millimeter slice thickness. The 64-slice scanners gave us about a 0.5 or 0.6 millimeter slice thickness and about 150 millisecond temporal resolution. And that was now getting down to the point where if we took the heart and we slowed it down with beta blockers, et cetera, we could actually get diagnostic pictures in a lot of people. And this is when The early studies on the 16 slice scanners were kind of equivocal as to the value of this technique. But once we got up to 64 slice scanners, we started to get much more positive results. In 2002, a 320 slice scanner came out that had about 0.5 millimeter slices and about 150 millisecond temporal resolution. The advantage of the 320 slice scanner is that the 64 slice scanners only covered about 3 centimeters of tissue per tube rotation. So in order to image the heart, you might need to cover 12 centimeters worth of tissue, which means you'd have to take a picture, move the table, take a picture, move the table, take a picture, move the table, take a picture. And each time you're trying to you're catching a different heartbeat, and the heart would be in a slightly different position. So we get these step-off artifacts between the different slices. And when we came out with the 320 slice scanner, that allowed you to acquire the entire heart in one tube rotation. So you could get rid of that misregistration between one slice and the next slice. But those scanners, there's only one manufacturer that had that, and again, quite expensive. And 2005 was the next big improvement. That was the first dual source scanner. The advantage of the dual source scanner is that they had 2 X-ray tubes and 2 sets of detectors. And because they had 2 X-ray tubes and 2 sets of detectors, for every time the tube rotated around, you could get 2 sets of pictures. Or you could combine them together and get one set of pictures, which allowed them to cut the temporal resolution from 150 milliseconds to 75 milliseconds. So you can think about 150 milliseconds as being about 1/8 of a second. Imagine trying to take a picture with your camera if you have a shutter speed, if you remember cameras that had shutter speeds. Imagine taking a picture with a 1/8 of a second exposure time. You're going to get a fair amount of blur. If you can cut that down to 1/16 of a second, it's going to improve things quite a bit. The current state of the art is a scanner that came out in 2022, which is what's called a photon counting scanner. I'm not going to go through all of the benefits of the photon counting, but this brought our spatial resolution down to 0.15 millimeters and the temporal resolution down to 66 milliseconds. And because of this photon counting technology, they could throw out photons that seem to be scattered. Imagine like fingerprints on your camera lens, get rid of that blur from scattered photons. And that got rid of a lot of the image noise and actually also allowed them to cut the radiation doses. And it was also helpful in decreasing calcium blooming. One problem that we have in CT scans, if you have dense structures like a calcified coronary plaque, has this process of blooming where the plaque looks bigger than it is. And if you have a calcified plaque that looks bigger than it is, it's going to make the stenosis, the narrowing of the coronary artery, look worse than it is. And the biggest problem with these scanners is that they are really expensive. They cost about 3 to 5 times the cost of a typical 64 slice CT scanner, which would be what would typically be used clinically today. So they are quite expensive scanners, and most places don't have these scanners. So how do we know that coronary CTA is good? As I said, some of the first trials were kind of disappointing, but 2 trials that came out and really showed the benefit of coronary CTA were the PROMISE trial and the Scott-Hart trial. And what they did, especially in the Scott-Hart trial, is they said, we're going to set up decision trees. We're going to say someone comes in with a chest pain, we're going to set up one decision tree that just has various standard tests. We can do blood chemistries, we can do exercise stress tests, we can do cardiac catheterization, but in the other side of the trial, we're going to look at those standard things, and we're also going to throw in coronary CTA. And what they determined is that if you looked at the various different decision trees, the ones that included coronary CT angiography were all superior to the ones that didn't. So this really demonstrated that CTA guided strategies, they had fewer cardiovascular events in the future compared to just stress testing alone. And they also reduced the need for catheterization. So the 2 things you kind of want to do with coronary CT is you want to decrease mortality. That's always, one of your endpoints. But you also want to try to decrease catheterization. Cardiac catheterization is an expensive procedure. It's an invasive procedure. There are risks associated with it. And we want to try to avoid doing catheterizations in people who don't need catheterizations. So we've kind of gotten to the point where we're looking at it and saying, well, what are the limits of anatomic imaging? That's what coronary CTA is. It's an anatomic structure. We're looking at the coronary arteries and we're looking for narrowings in the coronary arteries. And we are limited by temporal and spatial resolution and this blooming artifact that we get from coronary plaques. And we're also limited just by the lack of perfect correlation between anatomy and physiology. You can have a plaque which appears non-obstructive. An obstructive plaque is defined as a plaque of greater than 50% diameter stenosis, which is an area stenosis of 75%. And that's considered to be flow limiting. But you can have a plaque that looks like it's a 50% stenosis, but it has no physiologic significance to it. And you can have a plaque that looks like it's less than 50% that does have obstruction when you do a physiologic test. So how can we try to look at CT? Is there anything else we can do to supplement this anatomic imaging? So again, usually what would happen if you had a plaque and you weren't sure whether it was obstructive or not, is you'd send the patient for an exercise test. There are various different exercise tests you can do. You can use an EKG stress test. You can do nuclear medicine stress test. You can do stress echocardiography. You can actually do stress MRI using a pharmacologic as opposed to an exercise stress test. Various different ways of stressing the heart and seeing if you can induce ischemia, induce decreased blood flow. But again, additional tests that you would have to do at additional expense. Gold standard for looking for obstructive coronary disease is what's called an invasive fractional flow reserve. This is a parameter which is measured at cardiac catheterization. What you do is you do your cardiac catheterization, you get a catheter into the coronary artery of interest, and you then take a guide wire and you push it across that plaque. And this wire that you're pushing across the plaque has a little transducer in the tip that you can measure the pressure. You then induce hyperemia. You take the patient, you give them adenosine or an adenosine analog to try to maximally dilate out the coronary arteries. And then you measure the pressure distal to that plaque. And then you pull it back proximal to the plaque and you measure the pressure in the aorta. And if you look at the ratio of the pressure distal to the plaque to the proximal to the plaque, that's what's called the fractional flow reserve. And if that number is greater than 80%, it's considered normal. If it's less than 80%, it's considered abnormal. And this is our gold standard for functional assessment of the significance of a coronary stenosis. If you do a cardiac catheterization on someone and it looks like they've got a 75% plaque, but you check the fractional flow reserve and you get a number of 0.9, you're not going to treat that lesion. If you do one and it looks like it's a 50 or a 40% stenosis and you get a number of 0.7, you are going to put a stent in that or bypass that vessel. And this is again just demonstrating that diagrammatically. You've got your catheter in your coronary artery. Here's your lipid plaque here. You put the guide wire distal to the plaque, you measure the pressure, you then pull it back here, measure it proximally, and the distal pressure compared to the pressure proximally or in the aorta gives you your fractional flow reserve. So what can we do with CT? Well, in 2012, people who are much, much smarter than I am figured out a way to try to get this information out of CT. And what they do is you perform a coronary CTA, you develop a 3D anatomic model of the coronary tree, and then you'd get a physiologic model of the left ventricle. You look at the muscle thickness, you look at the enhancement of the myocardium, etc. You take all of this and you push it into a supercomputer, and it will, using various different parameters, it will solve various different equations to figure out what the blood flow is in the various coronary arteries. And this is a technique which is referred to as heart flow, or the company is heart flow. And they are currently the only approved process by the FDA. This requires an offsite computer and it takes 1 to 1.5 hours. There are other companies that have products, but they are not yet FDA approved. This is just to show you that process. You get your CTA, you get your model, you take it, stick it into the computer, bunch of complex equations, and they give you a readout. So the FFR interpretation, it normally falls off along the length of the vessel. The pressure is higher proximally than distally. Values greater than 0.8 are normal, 0.75 to 0.8 are equivocal, less than 0.75 abnormal. You measure 2 centimeters distal to the stenosis. And this is the kind of readout that we would get. If there was a plaque sitting here, we would look at this and say, okay, there's the value 2 centimeters distal to the stenosis. It's 0.72. That's a stenosis. Here's a case where you look at this. If you can see it here, there's a gray vessel here. There's a calcified plaque there. Looks like it's more than 50% diameter. But if you measure the FFRCT here, blue is good, red is bad. Numbers here, 0.88, not a significant stenosis. And these are some of the pitfalls that you can see here. Here you have a vessel, calcified plaque proximally. You measure 2 centimeters distal, and you get number 0.83. Looks like that plaque isn't significant, but as you follow it out, it drops to 0.64 at the tip of the vessel. So here there is no plaque-specific stenosis, but there is an abnormal value here. How good is this technique? Well, mostly what you'd like to do on FFR is what you're trying to do is, as I said, avoid cardiac catheterization. So if you look at these negative predictive values, an FFR in all but one of these studies showed a really pretty good negative predictive value. That means that the test is really pretty good. If you have a negative test, you don't have obstructive disease, and you can therefore avoid cardiac catheterization. So studies done to produce this, and they showed in this one study, the PRECISE trial, that there was a 70% reduction in 1 year of their major endpoints, which were all-cause death, non-fatal MIs, and catheterization without disease. So guidelines came out in 2021. They said coronary CTA, class 1 level A evidence, that's about the best clinical evidence you can get. FFRCT was labeled as class 2 with level B evidence for stenosis from 40 to 90%. So we're doing this now routinely on all our patients who have 40 to 90% stenosis. So in conclusion, FFRCT is proven to be a valuable tool for patients with stenotic lesions on coronary CTA, improves the specificity of anatomic imaging, decreases the number of negative catheterizations, and it can help you guide revascularization. You can look at those numbers and determine which patients, which lesions are the ones that need to be bypassed or stented, and which ones can be followed with medical therapy. And that's what I got.
Thank you very much. We have some time for a question or two. You have a question?
Sorry. So thank you for that talk. Fine. That was a really great talk. And so you hadn't seen previous talks on more methods driven, but this was great since you combined at the high level the clinical as well as the technical. I'm wondering, so this is kind of naive in terms of clinical application. Is the use of MRI ever used in a similar situation? Just because I would have thought that it is better contrast for soft tissue, or is the fact that the plaques are calcified make it enough contrast for CT?
MRI coronary imaging is a difficult nut to crack, and the biggest problem with MRI is that for CT, if you want to image a very small structure, you can take a very narrow X-ray beam and put a lot of X-rays through a small structure and get a lot of data out. In MRI, you're getting data out from the photon or the protons that are in the tissue. So as you try to improve your resolution in MRI, you have to make the little boxes of tissue that you're imaging smaller and smaller. So if you have, let's say, a 1 millimeter box and you want to make it a 0.5 millimeter box, you've now changed its dimension in 3 dimensions, each by 0.5 millimeter, which means that little box now contains 1/8 the protons that it did, which means it's going to give you 1/8 the signal that the bigger box did. So as you try to get sharper and sharper imaging, the other problem with MRI is that it has to be cardiac gated. You cannot get enough data out in 1 heartbeat to get a picture. So you have to do cardiac gated images. You have the problem with patients not being able to hold their breath long enough. So you have to do free breathing, and you do respiratory gating and cardiac gating to try to get the coronary artery into a stable position where you can get enough data out of it. And for things like looking at the anatomy there, CT is a much more robust technique. We do, for example, use cardiac MRI for looking at coronary arteries in young patients who might have an aberrant coronary artery, where you just really want to know where's it going. You're not really looking about whether it's narrowed or not. But it's very difficult to look at stenoses on cardiac MR. There was a paper that came out, I think it was like in 1997 or something like that, where someone reported great results, 100% sensitivity in 6 patients. But it really hasn't caught on compared to CT just because of the technical limitations of trying to get enough data out at the high resolution.
Yeah, thanks very much. I had a question about the case that you showed towards the end where you saw relatively, yeah, that's it, exactly. And yet, so you have the flow falls off, right, as you get to the finer components. Right. And what, do we know why that is? Is that a soft plaque?
This is assumed to be due to distal coronary artery disease. Now you look at this and you say, well, this vessel just doesn't look that diseased. It doesn't look that narrowed. So this becomes kind of a conundrum. But one thing you have to remember whenever we were looking at the coronary arteries here is we may be looking at like a 2 millimeter, 3 millimeter coronary artery in the distal vessel. But there are little side branch vessels, which are fractions of a millimeter there. And if those little peripheral vessels are all diseased, you're going to get a drop off in the flow there. And that's way below the resolution. I remember back in medical school, at some point, someone showed us a picture of a heart that they had injected with like a foam material and then dissolved away the tissue and just showed the thing. And the number of tiny little vessels coming off here is really quite astounding. It's just below the level of our resolution. So again, it's not fully understood why that's falling off. Because again, sometimes you see this in a patient whose entire vessel kind of looks like the proximal vessel here. It's just got little non-obstructive plaques all the way down. But I suspect that part of this is going to be in sort of that microvascular disease that is below our.
And then what kind of treatment is indicated for a patient like this?
Well, that's the thing, is that one of the advantages we have in doing coronary CTA is that most of the disease tends to be proximal. And that's a good thing for the patient, because if most of the disease were like in the mid and the distal vessel, you couldn't do a coronary bypass graft. You can bypass a proximal stenosis and jump to the good-looking distal vessel. But if the distal vessel is all diseased, you got nothing to bypass to. And it may also be the case, for example, in patients who have diabetes are known to have more sort of microvascular disease. And those patients may not benefit as much from bypass as patients who have, individual larger proximal plaques, because they just don't have a good, it's the microvascular which is disease, not just the macrovasculature.